Mark, for your information, our webinar is also on YouTube.
Fantastic. That's a great idea. Very good.
I'll give you the link shortly. All right.
Yeah, lovely.
Okay. It's about 9:30 now. Okay. Ladies and gentlemen, as I mentioned just now, tonight our webinar is going to be hosted by a very special guest, a good friend of mine from Australia. Okay, he is none other than Winthrop Professor Mark Tennant, AM or audio. Mark has been a member of University of Western Australia academic staff since the early 1990s. He is currently a Winthrop Professor, that I'm the highest ranked academic on UWA or University of Western Australia, and is currently the director and founder of the International Research Collaborative Oral Health and Equity and the Deputy Chair of Academic Board. Mark is also Director of Oral Health for the Country Health Service of Western Australia. In 2022, he was appointed a member of Order of Australia, that's the AM, Order of Australia, our services to the higher education and profession. Mark has a lifetime focus on addressing issues of equity and justice through reforming oral health. His team now is recognized globally as the leading oral health research and development group in Western Australia since 2016. Mark has been one of the handful of active nation leaders in peer-reviewed publishing in Australia in dentistry year on year. Mark remains the top dental academic of all time in Australia for impact with more than 250 publications and 20 million worth of R&D funding over the last 20 years. Mark has served in a number of executive leadership roles as a dean and head of school in dental schools in Australia. He led the resurgence of dental education in Australia, intertwining of love data system, evidence based on decision making, and with innovative strict. Mark has undertaken lead roles in the startup of Australia's newest dental school, all of which are regionally based and continue his lifelong efforts towards reducing social disadvantage and marginalization. Ladies and gentlemen, tonight, Mark is going to speak to us on the topic of the global challenge facing oral health in the 25 years, addressing global issues through innovation. Mark, the screen is yours.
Thank you very much. And it's really nice to be here. It's lovely to be here at 9:30 in the evening in my city, but in other cities, different times. I hope your day has been good. And I hope tonight will bring something interesting to you to have a think about and really to reflect on where we've gone in the last 25 years and where we're heading now in the next 25. And that's my plan for tonight, to do that. So my plan is to speak for probably 40 minutes or so, and then we'll have a good time for discussion at the end if that suits people. I'm more than willing to take questions and share stories. So the first thing I want to get started with is to remind us all, and I don't think many people need reminding, that we are an ageing population as a planet, really. The countries that most of us come from are all facing very significant ageing at the moment. And we can see that it's led by Japan. The examples I give at the moment, the year I was born, there were about 850 people in Japan over the age of 100, and today it's 85,000. So Japan is a great example. In one lifetime, it's aged as a population dramatically. It's at the leading edge, but all our countries are facing this same problem. We're going to have a lot more aged people than we are going to have young people. And the next 25 years, we're going to have to adapt to that change in expectations for what we need as a dental services across the world. The other major thing that I see in the world at the moment is a population and population distribution. We got a sequence of enormous cities growing dramatically. This is Sao Paulo in South America. It has the entire population of Australia in one city. 26 million, 27 million people in a single city. We have these mega cities, shall we call them. And then at the same time, we have populations distributed over extreme areas of, I describe it as salt and peppered population across large landscapes. So we have this extremeness of population distribution changes that we have to face up to and adapt to over the next 25 years. And we have to build services that reflect these differences in the distribution of populations across the world and how they are spread out in different ways and require different services. The other thing we're facing is that for many countries, and other countries are coming towards this, we are now getting to the situation where the core disease, dental decay, and in particular in children, is diminishing. The prevalence of dental decay in many countries is coming down. In this country, 60% of 12-year-olds have no decay at all. And it's only about 5 to 7% that have more than 2 or 3 decayed teeth in their mouths. So we now have a situation where many of our diseases are now diminishing in prevalence. And therefore, we're now starting to have swathes of our population without disease, but small pockets of population that have high levels of disease. And we know this is often associated with, or driven by, is more particular, socioeconomics. So we see in poorer regions much more significant disease burdens, and in wealthy regions we see far less disease burden as we get this gradient of disease burden across our populations. This is very different to as it was 25 years ago, where disease burdens were much more evenly spread across our populations. Rich and poor still had significant disease. And at the same time, we have a distribution of practitioners providing care that is the complete reverse of that. We have high densities of practices and practitioners in regions of high population, high net wealth, and high income generating areas. And where the disease burden lies in poorer areas, we have a paucity of practitioners. In Australia, tragically, we have some of the world's highest densities of dental practices in some of the wealthiest suburbs of our country. Whereas we have a huge area of countryside where there's, you can go hundreds of kilometres without finding a health service. So this is the classic inverse care law problem. And this problem is extending or growing over time when we're seeing more and more density of practices in wealthy areas and disease in poor areas. And the last thing I want to comment before I move on to the talk of these grand challenges is to talk about the answer's simple, just spend more money. Well, we actually know that the answer is not as simple as that. Spending more money doesn't always bring better health outcomes. And this is a fantastic graph that shows life expectancy. This is not dental, this is general health. Life expectancy versus a GDP spend per head of population on health. And you can see, sure, at the low end of GDP spend, as you increase spend, life expectancy grows. But the curve flattens off. And the return or the benefit on spend as you go higher is not an equal benefit as it was early on. And in fact, I've left one point off this graph on purpose. The point out here, the United States, the highest spend by a country mile, the highest spend per head of population on healthcare services, and a lesser life expectancy than many countries who spend less per head of population. So the United States is a great example of spending more doesn't get you more as a population for healthcare. So these, I think, are some of the important underlying features that we have to look at in the next 25 years as we think about dental care and how we address these grand challenges. And just to outline them in summary, the grand challenges, we have an ageing population. Whole swathes of our population are going to be elders, seniors, not earning money anymore from working, maybe on pensions and things like that. We have a population size growth and distribution that's now seeing mega cities and smaller distributions of populations across wider spread of land. We now have a disease distribution that is more looking like needles in haystacks. We have swathes of healthy population and small pockets of population with high prevalence of disease. And we're all facing the inverse care law, where services are located in places where the disease burden doesn't reside, and services are in those locations where there is high net income, whereas where the disease burden now lies, the services are not there. And to finish the grand challenges, we have the overarching grand challenge that spending more doesn't solve this. Spending more doesn't help address some of these grand challenges. Sure, we do need to spend more, but we also need to do it smartly. So I want you to use what I say to give you some thoughts about how we can do this more smartly. So let's talk about some of the things that I've experienced and I see about trying to address some of these problems with some smart solutions. And the first one I want to talk about is where we educate the next generation of practitioners. We know, I've shown you this before, that the vast majority of dental practitioners work in the cores of major cities, not where the problems lie. And we have a paucity of practitioners in rural, remote areas across nations across the world. We also know that if you train someone, if their training base is in a rural area, they are far more likely to work in a rural area. In fact, the multiplier factor is about 4, and that's across disciplines. There's not just dental. So a practitioner trained in a rural area is 4 times more likely to work in a rural area than a practitioner trained in a city. We also know that if we take people from school or from their education base in a rural area, so someone is already resident in a rural area, they are far more likely to work in a rural area after they're trained. So on that basis, the principle of putting more and more dental education in rural and regional areas of our countries can and has, in our case, contributed to a reduction in the inverse care law. We now have more practitioners heading out and working in rural and regional areas because we have placed 4 new dental schools on top of the I think it was 10 we had, 8 we had, 8 I think we had, core city dental schools. So we've added 4. One of them, for example, is 2,000 kilometres away from the nearest major capital city. So we talk large distances in our country, but the principle is the same. The other thing I want to talk about is having a think about how we provide care. The principles of a dental practice, as I was raised around early in my career, where you went to practice, you bought into the practice, and you worked there all your working life. That work-life model is not the modern work-life model. And we need to develop practices to address some of the grand challenges that reflect the work-life practices of modern practitioners and modern young people. This is what I call our mobile phone map. But it's not a mobile phone map. It's actually a map of every dental chair in Australia. And around each dental chair has been painted a 50-kilometre circle. The yellow circles are areas where there is a dentist in a community with that dental chair. The pink circles, the pinky purple circles, are where there is no dental chair, but there is 500 or more people and no practice. And the red areas are where, I beg your pardon, I got that the wrong way around. Purple areas are where there's less than 500 people. And the red areas are where there is more than 500 people and no dental chair or no dentist. So by using this sort of data analysis, we can actually work out the optimum locations to try and place new practitioners or new practices. We can target addressing the population needs. In fact, if we placed a dentist in every one of the red dots, there's 77 of them. We train about 550 dentists a year in this country. So if we were able to address those 77, we would only have 150,000 Australians living more than 50 kilometres from a dentist. And in my country, 50 kilometres is what people are happy to drive in the country. That's not a big issue for Australians. That's a small distance. So by using some of these sorts of modern geographic information systems, we can target where we address the issues of practitioner location to flatten out the inverse care law. But we are left with the pink dots. Places like this. Can you see the place? There's the town right there. It has a population of maybe 200 people on a good day. But to provide care, we need different models of care provision. In this case, this place has fly-in, fly-out care. 1 week a month, a practitioner with a student, in fact, flies out to this location and provides care in the location to then fly back to the city for the subsequent 3 weeks. Some of those innovative models of methods of providing care are what we need to sort out to address the last needs of the population beyond where we can actually place practitioners with a contemporary work-life model that modern dental practitioners want to live. I also want to talk for a few minutes about using other tools to address some of these grand challenges, using data smartly. Here's a great example of using the analysis of hospital data, primary healthcare data, integrating it together in a mapping project to work out where the gaps in a city are in terms of service need, to then reconstruct a government dental service to fill in the gaps. So using data, integrating data streams and analysing carefully, we can address some of the gaps in our service, in particular those gaps that are in the poorer, less serviced regions of our countries. And to use another example, some work from Sri Lanka, this was looking at water wells with different levels of fluoride. In Sri Lanka, some water wells have fluoride levels above recommended levels, and therefore for children, there is a need to look for the nearest appropriate fluoride water for allowing children to grow with healthy teeth. And using this tool, we were able to look at every single community and determine the distance from a high fluoride well to the nearest cooler well, to allow communities to make decisions about how they may address the water supply for the younger members of their community. These sorts of tools are very valuable in allowing communities to make appropriate decisions about how they're going to address their needs. And you can even get down to this level. This is some work out of Minneapolis in the United States, where we've been working on a house-by-house model of access to services. With modern GIS techniques, you can actually use every single house and measure transport networks and accessibility to health services on a house-by-house level. This is available to everyone. This work was done with no research money, with free tools and free accessible data. Everyone can do this sort of work. Here's the same thing again out of Plymouth in the United Kingdom, looking at public transport networks that bring you to dental hospitals and how the bus and train network could be optimised to give optimal accessibility for the poorer members of the Plymouth community to make their way to subsidised services. This is the opportunity that lies in using big data and data analytics tools to address these grand challenges over the next 25 years. Let's look at some more of these technologies that may bring us some solutions in this journey. The first one I want to talk about is the robots are coming. And if you haven't watched this video on YouTube, please go and watch it. Absolutely phenomenal. It's nothing to do with healthcare. It's Boston Dynamics who make the best robots in the world at the moment. And it's a lovely video. If you haven't seen it, it's actually 4 robots. One's missing from the frame I borrowed here. But 4 of the most top of the range robots that we have in the world at the moment dancing. It's a tremendous example of where we are heading with robots. The idea of robots being able to provide healthcare is coming. I have watched a robot stick brackets on a kid's teeth. It's coming. It's coming. And we all know about this already, that, you know, arch wires, the top 2 pictures are arch wires being bent by robots on demand to high precision. And the picture towards the bottom is actually a Da Vinci operating robot in an operating theatre that are currently in use around the world for robotic surgery. So these are coming to healthcare. It will take a while, but these will make a big difference. The other thing that will make a big difference is this machine learning stuff. We are only at the very beginnings of this journey, and its application in healthcare. This is actually out of the brand new Tesla system. This is real time looking at traffic flows in an intersection, so a car can travel without a driver through an intersection. But it is coming to healthcare. Already machine learning for reading radiographs. Much of the research shows that machine learning can actually read, say, breast screen radiographs better than humans can. So machine learning is coming to healthcare in all sorts of forms. At a simple now stage, we already see telehealth, and particularly during the pandemic, we've seen a much greater emphasis on telehealth to monitor health needs. This is one type of telehealth that we've seen happen. It's not my favourite. It's not my favourite because it requires a clinician at both ends simultaneously. So that's not scalable. That's actually, costing effort. But clinician to clinician telehealth is not unheard of, regularly used. Certainly in psychiatry, it's used quite expansively now. clearly, telehealth has the option to do remote supervision. And this is a great example. If you haven't read of the Alaska story, please go and read of the Alaska story about personnel trained to very basic level that are then supervised by telehealth systems to provide emergency dental care in communities that are snowed in and there's no other opportunity. This has been operating for some 20 years now and is effective, safe, and has worked well. So these sorts of models for some of those remote area locations are going to be solutions that we can take advantage of. We already see this happening in general healthcare. We see this happening in emergency rooms in remote hospitals where we can telehealth in, telepresence in ED specialists to support a team trying to resuscitate a person and things. So this is not completely new or unique to dentistry. But I think the real advantage of telehealth is, and we've seen it during the pandemic, is actually being able to return some of the control of healthcare to families. I think technology in general gives us huge advantage to return control to a family and return the ability to have knowledge to make informed health decisions. And if, for example, here's some work done previously from around our group to looking at a risk index and giving a risk index to different schools. And the idea was to make this public so a parent could look up and see the risk associated with their school and ensure that the services they are getting are in line with the relative risk that has been calculated based on a whole suite of variables that we know about the school from other data sets. Give control and power back to families. And this is the other part of what we've been working on, telehealth using basic consumer-grade phone cameras. And at first, it was horrifying. At first, I was shouted down for even thinking that this was possible. But we pressed on and we now see that this has been taken up in many places across the world. It got driven dramatically out of the pandemic, but it was starting to take off before the pandemic as well. Clearly, you need to understand the sensitivity and specificity of such a model. The good news is more recently, Mohammed from our group has extended the sensitivity and specificity numbers up past 80% and into the 90s. So for a screening tool, let's be clear, this is not about diagnosis. There's no x-rays, there's no, this is a screening tool. And remember, one of the grand challenges was finding the needles in the haystacks. So you can see where this is going. This is about screening children to say, hey, listen, it's a priority. You get in here now. Whereas, you're healthy, you can wait a little longer. As a screening tool, this is not a bad job. And then you come to the question of who do you need to read the photos? Do you need a specialist pedodontist to read these photos? No. These photos can be read by dental therapists or dental hygienists, depending on the condition you're looking at, and read well and with an appropriate level of skill. And clearly the future plans in this journey is to then integrate the machine learning part into looking at the photographs. That's going to be a while off. We're still in the early days of that as a discipline. It's still a long way to go on that front. For the moment, I expect that we'll still see eyes on screens, so as to speak, to do the looking at the photographs. So I'm going to stop talking there in a minute. Please remember, this discussion has been about looking at those grand challenges, the demographics, an ageing population, what we can do to enhance our distribution of healthcare providers, and what we can do to move beyond the traditional models of healthcare provision to address those grand challenges. So I hope that's been interesting. I hope there's a lot of questions and things to talk about, because I thought I'd leave a good amount of time for talking and sharing stories and adding to it. So thank you for listening, and I look forward to talking now. Thank you. I'll stop the share. There we are. Very good. Who's there? Oh, I'll put the chat on as well, because then I can see. If people want to, please, people, feel free to turn your cameras on and feel free to, are there any questions? You can type the question in the chat box if you want, if you don't want to speak. Very happy to answer any questions that you may have.
Thank you. Thank you, Mark.
No worries.
Right. So, yeah, just now, for questions, I think what I'd like to actually about the robots in the issue just now is robots for medical or dental.
There was two sets of robots I showed there. The ones at the top are actually bending arch wires. That's how, when you send away to have your arch wires bent, there's no humans bending them. Those robots bend them, and that's how they come back. So that's what that was. And the bottom one is called a Da Vinci operating system. Feel free to look them up. They're astonishing. Now, they're way out of the league at the moment. They're about, I think the last time I looked, they're about $8 million. But these are robotic operating systems. And in fact, and I'm not sure if anyone's actually done it yet, but in fact, you can put the internet between the operating machine and the surgeon. So they don't even have to be in the same city or country. In fact, they could be on the International Space Station. But I'm not sure they've got that far yet with them. I think there's still concerns. So they are still used by the operator in the room and the theatre. So yes, those are used in healthcare quite regularly. There's two of them not 300 metres from my home, 400 metres from my home. So they are regularly used. For dentistry, they're still experimental. I've seen a couple in action, particularly, bracket sticking. I've seen one doing that in Amsterdam a while ago now. But yes, they are coming. And you know what? I think when they do come, they're going to come with a rush. And I think they're going to come to disciplines like orthodontics. I think they're going to come to disciplines needing high resolution, continuous movement stuff. If I was a young person starting out in dentistry and thinking about what specialty I would take on in my life, my tip is probably pick a specialty that has a bunch of behavioural stuff in it, be it oral medicine, oral pathology, pediatrics, behavioural biology. I think the robots are going to be last in those patches of land, but they're going to come. They're going to come. Now, I saw a question on the chat here. Let me just do this for you. How does... I'll read the question out so everyone can hear what I'm talking about. Thank you, Prof. Tennant. No problem. My question is, how does those extensive research that you've done, thank you, translate into real public policy implementation? Can I tell you? That's what all this grey hair is caused by. All this grey hair is caused by the journey of translation. Research is actually relatively easy. Research we can all do and we can think about and we can go, oh, yeah, that's a great idea, let's try that. But to actually translate that into policy action takes an enormous amount of effort, time, and persistence. If I leave you with one message on that, it's persistence. Never, ever give up. So the stories about those dental schools in rural and remote Australia, that's 20 years of persistence, 20 years to get to that. So don't expect policy change to happen overnight. There is an enormous amount of inertia in policy and government positions. I'll be honest, there's often invested interest in government positions. So to make change takes time and effort. You know, the old two steps forward, one step backwards, or whatever it is. That's the life of policy change. Tremendous question, though. Really important thing to talk about and be open about.
Yeah, there's a follow-up to that question, Mark.
Yes.
What are factors that might affect government priority and resource allocation for the envisioned equal access to healthcare?
Yes, and you know what? That's a really difficult thing, isn't it? You need to find, when you want to change something in a community, you need to find what drives the policy people for them to want to make the change. That's the art in this, is to find what they want. For example, let's imagine your research shows that it'd be really good if you put a dental school in location X, but you know a dental school costs $20 million to build. How can you get a government to participate in that? Well, you have a good think and you go, what are the worst nightmare problems that a premier or a prime minister faces? And they are embarrassing questions in Parliament. So if you can find a way that you can say, all those questions you get about dentistry in location X, Y, and Z, we can get those questions away from you by doing this. You need to find what they want an answer to connect to then make change. Don't go with your evidence and go, you must do this because I'm telling you to do it. They're not going to listen to you, me, or anyone. You've got to find what they want and match what they want with what you can achieve. I think that's the way forward in policy. It's not easy. It's not easy.
Okay, Mark. Our Vice President is here, Professor Ashraf Malik. Just now I saw he raised his hand. So, Professor Ashraf,
yeah. So, Datu Ibrahim, Assalamu alaikum, and it is so wonderful that so exciting lecture it was, and so exciting data it was produced. My question is that whether this data, you have seen the two countries' data. One is of a very developed country, that is Australia, and the second is you have seen a moderate or underdeveloped country, that is Sri Lanka. Whether this data is applicable to every country, and the calculation which you have rendered is we are going to face in 25 years, or what do you think that it will be coming soon after 10 years or 15 years? The distance I want to see that it is not 25 years. I think that the speed of the technology which is going on there, I think that this we are going to achieve within 15 years rather than going for the 25 years.
You know what? I think that's a tremendous comment. I think we underestimate the speed of change. You look at, personal computers or our phones. If you'd said 25 years ago, you would never have guessed where we've got to. So I totally agree with you on that front. I do want to point out, although much of my data was from Australia, or a developed country, the vast majority of our work is in, we work in Iraq. We've done work in, many developing places. And the data sets we use, those open data sets that I said, we don't have any money for research. Even though we're in a first world country, there is no money for research. So we use the open data sets that are available and integrating them with freely available tools. Every piece of what research you saw today was done without a single dollar being spent on it. Not a dollar. It's this thing that did it.
That is,
You know, so I think that's really important for people to understand. If you've got a passion for something, there is lots of open data around now. There's a lot you can do. There's a lot you can do with this. This thing has the longitude and latitude in it. You can measure longitude and latitude with one of these. Drive to all the clinics in your district and get the longitude and latitude off your phone. Use OpenStreetMaps. There are many, many ways to do this. You know, we're just doing some work in Mongolia at the moment. So, you know, this is, I'll tell you personally, the tragedy is I don't get to visit these places anymore because there's so much free data. I do it from home. You know, I'd love to come and see some of these places, but I don't need to. So please, I think you're right. The speed of change is great and the opportunity is great. The opportunity is great. We have so much opportunity to do all sorts of good things. Thank you.
thank you. Thank you.
Okay, Mark, there's several questions. Now, one I'm going to read to you is from the Q&A from Dr. Shantala. She's from Cook Dental Institute. She said, my question is, which is one of the challenges we will be facing in future? Will be training dentists or adopting changing technology in dental practice?
Yes. Can I tell you, I was trained, I think some of you won't even know what this is. I was trained to do gold foil restorations. I don't think anyone other than Ibrahim, maybe you're my generation, you might remember them.
Yeah.
They were, the technology, well, in fact, my first practice into dentistry, we didn't use gloves. Gloves were outrageous. You know, that you won't be able to do fillings with gloves on. Nowadays, you know, so yes, the speed of technology change and how we train our dental students, you know, is going to be, it will remain an integral problem that we face. I don't think, I have great faith. I think the next generation are just so born with these things glued to them, or their computers glued to them and things. I think their ability to take on technology and to advance technology is far better than the generation behind us. What I find in new dental schools and new dental hospitals is the students take on using the computer system while the senior staff still want to use their medical record with their biro and things. So I actually have a positive perspective on dental students and the future. I think their adaptability to change is far greater now. They've seen far more change than we ever saw. So I have hope on that front, but you are absolutely correct. It's not going to be, well, it wasn't even for generations before ours. Train and you keep that skill set for life. That skill set's going to change all the time. So absolutely correct. Great question. Really tricky problem, dental schools. Very political decisions on what we all teach, huh?
Another political question you want to is in the chat, Mark.
Yes.
I personally feel that there will be always a fight for healthcare resources against other priorities such as defense, education, transportation, etc. So the size of it matters as well.
Oh, without a doubt, without a doubt. You know, the political balancing between priorities in a country, you know, health is not always at the top. In fact, I think it's become more and more evident that health is not at the top in the last 3 years with the pandemic. You know, I look at my own country, I thought health was quite high up in my own country, and over the last 3 years, it's sort of, in my mind, slipped down the ranking. So that is absolutely a grand problem that we face, that health. And then you look at dental, you know, in this country, I think it's less than 3% of the total health budget is spent on dental. So, you know, we're in a professional piece of health that doesn't get a high priority in the health system either. And frankly, I'm not too concerned about that. I would rather a good amount of resource be spent on our, high impact diseases, cardiovascular disease and things, and dental take a smaller seat in comparison. But I do want a reasonable share. So yeah, it's not that battle will continue. We all need to continue pressing on that battle.
Okay, thank you, Mark. There's another question from Dr. Munira Faizi. She is, I think, one of our public health residents. We are heading to aging population. Do you think that we should have specialty in dental geriatrics, like PEDS, dental that's focus on the kids?
Oh, can I answer in 3 letters?
Oh.
Yes, absolutely yes. We are going to have to see. We've had all these school dental services since the 1960s in many countries, and we've got them. Hong Kong, Malaysia, I've seen them everywhere, Indonesia. We have these school dental services that are very substantial, probably eat a big chunk of our budget. They've been extraordinarily successful. Let's not be crazy here. They've done a wonderful job, coupled with the great preventions, fluoride, etc., that's diminished the disease burden. And that element of the population is shrinking. So in my view, the next 25 years, we need like the seesaw. We need a resource and effort allocation to move towards the older population. That's going to be a much more complicated problem, but that's for the generation to solve. And to reduce our focus on the child thing, we could probably put more technology into it, the smartphone screening, etc., and at the same time build up the aged component of our system. That is, I think, one of the core challenges of the next 25 years. So absolutely correct. Spot on.
Okay, there's another question, again from, I think it's not mistaken, it's from Professor Adam. Is there a standard dental curriculum in Australia, or each university is given enough freedom to decide on its own?
That's a tremendous question. And this is a debate across the world. So wherever that question comes from, please don't feel lonely in your debate. Just so I'm clear, in Australia, there's a fair bit of independence about what dental schools can do and teach. There is a accreditation framework that gives them sort of general principles, but it's not prescriptive. In fact, it's not even prescriptive on hours. You don't even have to do a certain number of clinical hours, which frankly, I think is a problem, but we'll let that go. But that debate about central control versus local control is a debate that goes on dental schools all over the world. If you want my personal perspective, I think the idea of localization and local power to determine a curriculum with some sort of, basic principle over it, you've got to be sensible, of accreditation. I think I'm a protagonist for localization because every community has a slightly different mix. Let's take, for example, oral cancer. A friend of mine in Sri Lanka said, "Oh, Mark, if I don't see, 2 oral cancers in a day, I've missed one." And in Australia, we worked out that in a lifetime of practice, you may see 2. So clearly it needs localization. Something generic doesn't work. So I like the principles of localization. I understand that's not the case in many countries, so I'm sorry, but that's my perspective personally.
Okay, I don't see any more questions. I just want to ask you something about what you said. You built dental school in a rural area, hoping that they will practice in the rural area. From the 4 dental school, the new dental school in Australia, especially the one in Cairns, if I'm not mistaken, the one.
Yes, Cairns.
To say that the graduates there work there?
We do. And the answer is yes. They've been operating now 15 years. And just to give you some measures, you know, a normal, a city-based, one of the old city-based dental schools, you'd probably see at best 5% practice rule after graduation. James Cook Uni, the one up in Cairns, the most extreme one, we're talking 75%. So we're not even talking a small margin. We're talking just a phenomenal margin. And similarly across the other regional schools, we are seeing a significant proportion. But I think that's because it's taken into account the two core known factors across disciplines. You know, they've taken a significant number of their intake is from, you get a weighting, you know, you get extra points to get into the school if you've been living in a country area. So if you're a kid from a country, you'll get a seat at the dental school more than a city kid. And I think the other thing is because they do lots and lots of outplacements, these modern dental schools are all what I call dental schools without walls. Their clinical program are placement programs spread out in regional sites around the school. These schools do not have the traditional, you know, Harvard castle of a dental school. They are distributed model schools. And so they've been highly effective. The other thing I will say about particularly the James Cook one, Australia has a First Nations people. We call them our Aboriginal and Torres Strait Islander people. Very marginalised group in our community. Just to give you an element of their marginalisation, their life expectancy is something like 15 years less than the life expectancy of the European-based population. So, until James Cook University, there had only been 6 Aboriginal and Torres Strait Islander people as dentists in our country. And they have trained, I've forgotten the number at the moment, it's about 25. So in that marginalised sector of our community, they have made an absolute critical change to the situation. So yes, this has been successful based on those two core factors that we knew from the very beginning that those factors were the core to the story.
Yeah, thank you. In fact, our university policy now to take students from the local area, so that they hope that they will go back and serve after graduating from in not just dentistry, in what other disciplines too.
Yeah, to be honest, I think that's a tremendous thing. I get very concerned. One of the if a vice chancellor says, "Mark, would you come and help me start a dental school?" I have 2 rules. One rule is I want to be able to spend as much as I like building Optech, the simulation lab. So you just that's where I'm going to spend money. So if you're happy, that's fine. And the second one is we are only going to have about 10% international students in this school. Because most dental schools are for local communities. This is about addressing the health needs of a local community, and local taxpayer money has been put into we only have government, by the way. We don't have any private schools. These are for local communities and local tax money. So I absolutely agree with your principle of localisation and focusing on your community first. And then after that, sure, once your community is good, grow out from there. That's good.
Okay, thank you. I saw one question just coming up in the chat, Mark.
Yes.
I think there's some sort of freedom needed to address the current and future challenges, such as adapting to technologies. I think this is follow-up.
So, let me read that again. Do you think that some sort of freedom is needed to address current and future challenges, such as adapting to? Yes, I do. Yes, you know what? And that's the advantage of having a strong academic community, dental academic community within dental schools. I think we should support our dental schools and allow them to be strong, because then you can have academics who have some of that freedom, you know, with proper ethics approval and all those sorts of things, to be able to test new technologies and bring them forward into the community. If we don't have strong dental schools and we don't support the personnel that work in our dental schools, then we as a community are in deep trouble. Academics are a core piece of that innovation hub that brings these sorts of things to the fore. So, and I know in many places, you know, being a dental academic, I don't know about you, Ibrahim, but I think being a dental academic is not, is a lot of hard work, and a lot of stress. And we find that lots of academics, modern next generation academics, are worn down by it and head towards practice because it's not fun anymore. And so I think everyone, it's a responsibility for all practitioners, wherever you are, to support your local dental school, to give your local academics a tap on the back, to celebrate them and support them, even just with mental support, I think is really important. Academics are a core element of that question about testing things and trying.
Okay, all right. I think we have a really long discussion tonight. Thank you very much, Mark. On behalf of ICD Section 15, we'd like to thank you for you to share some of your thoughts and your thing that you experienced from your vast research work that you conduct in Australia. Okay, and we'll sit able to spend this evening with us tonight. Thank you very much on behalf of Section 16. All right, thank you, Mark. Okay,
absolute pleasure. Thank you.
As usual, our next month in August, we will have a monthly webinar. So I will introduce the speaker for the next meeting. Okay, the speaker for next meeting is going to talk about aesthetic in maxillofacial radiology based on 3D printing. This is technology, 3D printing, and the speaker is Professor Dr. Zainal Ahmad Rajion, and he is the Dean of International Islamic University in Malaysia. So that is in about a month's time, on 17th of August. So please do join us to this present lecture on aesthetic on maxillofacial radiology based on 3D printing. Okay, with that, I think this will end our session tonight. Thank you, Mark, and thank you all for joining us tonight, and see you all again in August. From August, I think we'll be doing, instead of once a month, the webinar. So the first one will be on the 17th of August. Thank you very much and good night. And on behalf of our education committee, Dr. Mayuna, Dr. Amy, and so thank you all to come for our tonight's webinar. Thank you and good night. Bye-bye.
Thank you.